Welcome, everyone. It's so nice to see so many people joining. I'm just saying that quietly because the numbers are kind of going up as I speak. Everyone always joins quite literally in the last 15 seconds before it goes bang on 11. So I'm beginning to notice a pattern here. This is going to be our third session. It's the first time I've ever had a surgeon join me for Intelligent Finals. I've been in a little bit of a one-man band for the last several years, actually. And because I haven't done surgery in such a long time, I don't think it's credible for me to teach surgery. And I really wanted to have someone competent, i.e. a surgical registrar who really understands the stuff and has done MRCS exams and therefore is quite good at exam technique and understands this in a much deeper level than I ever could to really be able to teach surgery. Thankfully, I've been joined by my colleague, Corti Linder, who is a general surgeon in London. He is here to teach you all about right upper quadrant pain. I'll be quietly listening as well in the background and monitoring the chat because there's two of us. I can keep an eye on the chat this time. I think the format that we've done last time, and of course, nothing is hard and fast, will be kept again. So just be aware that the speaker is not necessarily watching the chat because the chat in the corner takes up space and you can't see your slides. So what I'll do is I'll keep an eye on the questions and we can probably field them towards the end. Before we begin and before Corti starts, I do have a little shout out to make. I am beginning to realize rapidly that Intelligent Finals is generating a lot of work, even more so than last year. And what we are looking for is some people who may be interested in to join us in some capacity. Now, before everyone starts messaging me immediately, excitedly, I'm going to put some details on the Facebook page. There's going to be a little Google form. It's not an enormous application process. It's not that formalized. But if you do have any interest in the kind of things we're looking for or have an interest in joining us, then please do get in touch. I know some people have already reached out to me over the last few months on email, and I've been terrible at responding. So if you are listening to me thinking I've already got in touch with them, then I will message you back. I have a list of a couple of people I'd like to speak to anyway. So the things we're looking for are creative individuals, people who can help us with social media and posting, people who will help us advertise, or even if you can be a representative at your local university and be part of helping us organize this year's course, then we'd be interested in speaking to you as well. We need one person from every university. So if you are interested in any of that, the Google form will be active in the next 10 minutes on the Facebook page. You don't have to rush. There's no time limit. I'm going to keep a look at all the responses and read everyone's kind of post statement. I may not respond to everyone who gets in touch, but I will be selecting people to kind of, I hate the word interview because it's not that formalized, but we will be looking for people to join us. So if you don't hear from me, I do apologize. But if you do hear from me, please let's speak some more. Okay, great. With that said, I'm going to now introduce Corti. Can you hear me? Hopefully you can unmute yourself and share your screen.
Hello, can you hear me?
I can hear you loud and clear, mate.
Excellent. All right. Hello, everyone. My name is Cortland. I'm one of the surgical trainees at Royal London Hospital. And today I'll just be chatting to you about right upper quadrant pain, going through the clinical presentations and investigations, etc. Okay, so the first thing I just wanted to cover is what are the differential diagnoses of right upper quadrant pain. Here's some of them I've written down. I'm sure there's a few more, but the main ones that I'm going to cover today, being a surgical trainee, are biliary colic, cholecystitis, choledocholithiasis, and ascending cholangitis, which are all gallstone related diseases. We'll go through some of the definitions, etc. in a while. When someone does present with right upper quadrant pain, other things you might consider are things like hepatitis, basal pneumonia, and myocardial infarction, some of the other differentials. But we won't really be covering those too much today because those are quite often dealt with the medical teams. So the first thing I'm just going to recap is a little bit of anatomy, just because I do personally find this area quite confusing. And so just understanding this quick anatomy does help you to work through your differential diagnoses and understand the presentations. So here you have on the left a picture of the gallbladder. The important thing to note about the gallbladder is the neck of the gallbladder, because that's where often stones can get trapped Bile is stored there. It goes via the cystic duct to meet the common hepatic duct, which drains bile from the liver. And then they form the common bile duct. This then goes into the second part of the duodenum, as you can see on the picture on the right, through the ampulla of Vater, where it also meets the pancreatic duct. So the most important things for these ones are the cystic duct and the common bile duct, which can cause a bit of confusion, actually. So just quickly about the gallbladder, just to recap. The gallbladder stores bile, which contains cholesterol, bilirubin, and bile acids. So the bile acids are used to emulsify fat, and the cholesterol and bilirubin are just basically waste products. And normally has about 0.5 to 1 liters of bile per day. And it's stimulated by cholecystokinin, which is released when you eat fat. The stomach releases cholecystokinin, simulates this rhythmical contraction of the gallbladder and opens up the sphincter and around the ampulla. So that rhythmical contraction is very important, we will see later for all the gallbladder diseases. It's inhibited by somatostatin, so they kind of work in tandem. The gallstones. Gallstones normally can be formed by cholesterol within the gallbladder. It's insoluble, so it can form these quite large stones, sometimes bilirubin. The risk factors that's often examined, we say the 4 Fs. So fat, female, fair, and 40. Quite often in exam questions, they will include those in the vignette, and sometimes it's quite important to look out for those. And just the gallstones, they can be quite large, actually, up to 2 or 3 centimeters, maybe more, and really pack the gallbladder. So quite often, once you've formed a gallstone, you are going to be forming them for life. If you're the type of person that forms gallstones, you probably help them for life, unless we remove your gallbladder, of course. Right, so just on the definitions I was talking about before, so all of these sound pretty similar, I must say, but there's choledocholithiasis. That's the presence of gallstones in the gallbladder. So I think lithiasis indicates stones. Chole is gallbladder or bile. So that's just having gallstones. It's a fancy way of saying it. Biliary colic is intermittent pain when the gallstones are trapped in the neck of the gallbladder. So that's, as we were saying, this rhythmical contraction of the gallbladder can cause biliary colic. The next definition is cholecystitis. So that's when you have a gallstone that's trapped in the neck, but is causing inflammation of the gallbladder. And then the final definition is choledocholithiasis, which is a fancy way of saying that the gallstone is trapped in the common bile duct, which we'll discuss later. So those are just some names that can be thrown up in your exam. It's just good to be familiar with them. Okay, so we'll go back to the right upper quadrant pain and discuss about how someone with biliary colic can come in. So classically, it's a colicky pain, which means intermittent. And I always thought that this meant, comes on 10 minutes and goes. But actually, I found often this pain comes on for, up to 30 to a few hours. It can be at 30 minutes to a few hours, and it can be pressing and constant while it's there, and then it relaxes. And then, then it relaxes, and then it comes back on again. So that's a quite a classic presentation. It can often be in the right upper quadrant, but sometimes it can be epigastrium. There's often this saying that the first episode of biliary colic will be an epigastric pain. After a while, it will shift around to the right upper quadrant, which is basically in the same way that often an appendix does. As the inflammation of the gallbladder increases, it starts pressing on the the peritoneum, which is more easy to localize. The pain is often triggered by fatty foods, and patients will sometimes notice this, but a lot of patients don't notice that, and it's important to just even asking that question early on helps management, because you do make them aware that this is one of the causes. So you have nausea. Some people vomit maybe 1 to 2 times. If you're vomiting a lot, that indicates it's probably less likely to be gallstone related. So if they come in and they vomited 10, 15 times, indicates to me something that's more like gastritis. 1 or 2 vomits with pain is more typical of biliary colic. Loss of appetite is a really good sign for anyone who you need to figure out if they really are in pain, or if you're not quite sure. If they've lost their appetite, it is a good sign that there's something going on. So the observations for biliary colic will normally be okay. Actually, I think they sometimes they might be a little bit tachycardic with the pain, but they shouldn't be feverish. If they're feverish, you think there's something else going on, and normally they should all be apyrexial. And then finally, examination. So the examination in the abdomen is key, making sure they're flat, so they're not tensing their stomach muscles, making sure they're relaxed. And often a trick is to talk to them while you're examining them, because people can often be quite scared in the hospital, or you're not quite sure how severe the pain is. So just talking to them, often I ask about their work, just completely relaxes them. And then while they're not, well, obviously you ask permission, but while they're relaxing and not quite focusing on their tummy, then you start feeling around. So the right upper quadrant tenderness normally should be quite clear, just under the costal margin. If you press, should be tender. Shouldn't be too much guarding, which means that when you press, you can feel their muscles contract. And there should definitely not be peritonitic for biliary colic. And the way to check that is, as I said, try to distract them while you're examining them, and percuss their tummy. And they shouldn't have pain on percussion, and they shouldn't jump out of the bed when you're percussing. If they're jumping out of the bed when you're percussing, then that signifies something else. And there's Murphy's sign, but I'll go on to explain that in a few slides. Just quickly talking about the biliary colic, why is it that you have this pain in this fashion? So the fatty foods, you will eat them and they release cholecystectomy, which stimulates the gallbladder to contract and push out bile. If there's a stone present, it can get trapped in that neck, and then it causes the pain. What happens is that as it's rhythmically contracting, the gallstone can get dislodged and then come back and get stuck again. So that's basically why you have this intermittent colicky pain. That's the basic physiology. So what are you going to do when someone comes in with right upper quadrant pain? The investigations are pretty similar, actually, for any of the differential diagnoses. The most important, I think, first step is to do a urine dip. Is key thing, because the other possible differential here is a renal stone, renal colic. So that might have blood in the urine, or might, pyelonephritis might have nitrates, leukocytes positive. So just trying to preliminary exclude those is really key. And with urine dip, pregnancy, of course, always. Observations, as we were discussing. Then for bloods, what you're going to send off: full blood count, urea and electrolytes, CRP and LFTs, bone profile, which includes calcium, phosphate, these kind of things, and then a clotting screen as well is key. So I'll discuss LFTs in a bit. FBC is important. You want to see the white cell count as well as the CRP for inflammation. Using these, we want to look at renal function. If you're septic, you can have an AKI. It's quite important to know. Bone profile, calcium, if it turns out to be pancreatitis, then you want to have a calcium. That's the other thing I haven't mentioned here, but essential for any abdominal pain is lipase, because you don't want to be caught out thinking it's biliary colic and then it turns out to be pancreatitis. That happens, and it's not good. And clotting screen, if it's a derangement, if it's a liver derangement, the INR clotting function can be off. So it's essential to know that. Erect chest X-ray is always a really good initial investigation as well. So you can exclude any perforation. So either if the gallbladder is perforated, or if there's a duodenal ulcer or that's perforated, you might see pneumoperitoneum on the X-ray. So it's pretty easy, quick test that you can do in A&E. All of these can be done very straightforward in A&E any time of the day. So really good to get done. And then the final, most important one is ultrasounds. So we'll talk about liver markers. So the main ones that you're looking for are alkaline phosphatase, ALP. So this arises from the liver, bone, placenta. So it's not very specific, but it does indicate liver function. So it's quite useful. So the transaminases, so these ALT and AST are actually the markers of the liver function. And if the liver is injured, they will be raised. And bilirubin, obviously, we're dealing with the drainage of the bilirubin, so it's quite important. So this is just a kind of rough guide of how to make a diagnosis with bloods. If there's cholecystitis or biliary colic, quite often your bilirubin should be completely normal. Your ALP and ALT may be slightly raised, sometimes just because of the inflammation that's going on around it. They may be slightly raised, but none of these LFTs should be particularly raised. If you have properly obstructed your biliary tree, so if we have a common bile duct stone, then your bilirubin can't drain. So that's going to be quite raised. And it's mostly conjugated bilirubin because it's an obstructive picture. Your ALP should be quite raised as well. But your ALT, AST of your liver function often aren't as raised as your ALP. On the other side, if you have hepatitis and a more medical, viral hepatitis or any other cause of hepatitis, your ALP should be raised, but not quite as much as your ALT and AST. So that's a kind of rough guide when you're looking at the bloods of how to differentiate them. Okay. So next thing is ultrasound or ultrasound or CT is a key question. So the gold standard first line investigation for gallstones is ultrasound, and it's a really good test, actually, a really good investigation. It can see the gallbladder, it can see if it's inflamed and thick-walled, and then it can see if there's gallstones. So you can look through the cystic duct to see if there's any gallstones in the cystic duct or the common bile duct, and whether they're dilated. Sometimes they may not be able to see the stones, but they can see dilation of the duct. You can do a CT, and quite often some of these patients, if they have severe pain and it's nighttime, A&E, or you might think it's appropriate to get a CT just to rule out anything else. And CT can actually show some cholecystitis, and it can show a dilated duct, but it's almost impossible to see a stone on a CT. So even if you get a CT with this patient, they still will need an ultrasound in the morning to find out where the stones are. Sorry, there we go. So management of biliary colic. So you've done the investigation, you've found out it's just biliary colic, straightforward, nothing else. So main point is painkillers, analgesia, they're in pain, it's important to fix that. Then you want to manage it in the community most of the time. They don't really need a hospital admission for this. As I said, tell them to avoid fatty foods and then they'll need an interval laparoscopic cholecystectomy as an elective basis. So, maybe in 6 to 8 weeks' time, you can try to get them for a lap chole. Okay, so we're moving on to cholecystitis. So, similar presentation, can be similar pain, right upper quadrant, colicky, can often radiate to the right shoulder. As the gallbladder is inflamed, it's pressing on the peritoneum. It can cause pain in the right upper quadrant, but also in the back that goes to the shoulder. Fever, nausea, common. Fever is the key. It's very important to look out for, and can help make your differential whether they're going to stay in hospital or go home as well. They might be tachycardic. They may be tachypneic. Look out for tachypnea as a sign of early sepsis. On examination, as I said, right upper quadrant pain, and then Murphy's sign is a good thing to look out for, and it's something they may ask you in your OSCEs. So what you do is you put your hand on the right upper quadrant, and you ask the patient to inspire. And as you inspire, you just slowly put pressure on. And if you have an inflamed gallbladder, as the diaphragm contracts, the diaphragm moves down, the gallbladder pushes up against your hand, and that will cause their pain, and they'll stop mid-inspiration. Okay, so it's pretty straightforward, and you sometimes don't even need to ask them to breathe in. You can just watch their breathing and do it. And I do that sometimes as well, because again, it's all important to distract the patient to make sure they're not so focused on the pain, so you can really see how tender it is. So that's a good sign, and that will, if you have an abdominal examination, your OSCEs, they will quite possibly ask you that. So investigations. So you do all the investigations I suggested before. The specific ones for cholecystitis and blood, so inflammatory markers will probably be raised, so white cells and CRP. You might get a slightly raised ALP and ALT, normal bilirubin, normal lipase. Ultrasound, these are the things we were talking about. You can get inflamed gallbladder, you can maybe see a stone. The important thing with cholecystitis is that you want to see from the gallbladder, from the ultrasound, that they've seen the common bile duct and it's normal size. That's one thing that you're really thinking. You've got a patient with cholecystitis, they have an ultrasound. I need to make sure the CBD is not dilated. So management. Most of these people admitted, both because they're a bit feverish, they can become septic, and also they're in a bit of pain. So IV antibiotics, IV fluids if they need it, analgesia, morphine, paracetamol. PPI depends on which hospital you work in. Some start everyone on a PPI, some don't. We don't in my current hospital. And then, so the guidance is changing about laparoscopic cholecystectomy. So it used to be that they advise not to do it as an admission, but nowadays the guidance is increasingly suggesting that if you can, to do what's called a hot laparoscopic chole in the first 48 hours is a good idea, because it's not so inflamed that it's a difficult procedure, and it helps resolve the cholecystitis without leading to any complications. And then if that doesn't happen, then they can have an outpatient laparoscopic cholecystectomy in 6 to 8 weeks. In real terms, we don't often do hot lap choles because of the emergency surgery lists are always busy, and this isn't an essential. In most people, it's not essential for them to have the surgery. So in our hospital and many others I've worked in, it's mostly been for an interval lap chole, but it's ideal if they can get it done. So Choledocholithiasis. This is when you have the gallstone that's trapped in the common hepatic duct, or in anywhere downstream of that biliary, common bile duct, anywhere downstream of that biliary tree. So you have a very similar presentation to acute cholecystitis. The one thing I've noticed just from my own observations is that sometimes the pain can just be constant rather than being colicky. It just becomes a bit more constant pain. Right upper quadrant. Bloods, you'll have raised LFTs. Bilirubin will be raised, and that's your thinking. If you've got right upper quadrant pain and you've got bilirubin raised, you're thinking there's some blockage of the biliary tree. So ultrasound is again really helpful, and it can show dilated ducts. So the dilation of ducts is relative to age as well. So as you get older, your biliary, your common bile duct gets a little bit larger. So it's important to be aware if it's like 8 millimeter and they're slightly older, then that might be fine. And if they're younger, that's a bit too large. And then so that's important. And then if you do have a dilated duct, the next thing is an MRCP. This is MRCP. This is a magnetic resonance cholangiopancreatography. So it's an MRI basically that looks at your biliary tree. And this is, so after you get the ultrasound and you show dilated ducts, you'll get the MRCP, and this can show exactly where is it dilated and what's the cause of the dilation. So is it a duct is it a stone that's trapped in the duct? Is it sometimes you can get sludge that the ultrasound can't see, and it can be malignancy as well, either a stricture or a tumor of the bile duct that's causing this blockage. Right. So if you do have something that's blocking the biliary tree, then the next thing is the ERCP. So while it's named, it's quite similar. It's just completely different investigation. Endoscopic retrograde cholangiopancreatography. So it's an endoscope. So you put it past the endoscope down the esophagus to the second part of the duodenum, where you get to the sphincter vodi, and they can pass all sorts of wires and instruments through up into the biliary tree. And so one of the things you can do, multiple things when they're down there, they first will inject some dye into the biliary tree so they can know exactly where the obstruction is. They can retrieve stones with different wires and everything from the biliary tree, and they can also widen the sphincter to make sure the maximum amount of bile is passing. They can also pass stents if there's a stenosis to allow the flow. So this is just to remind yourself of the anatomy, and then here you can see on the right the ERCP, the endoscopy is going down to the duodenum and then injecting dye, so you can see really nicely the biliary tree and the gallbladder off to the left. So laparoscopic cholecystectomy. So this is keyhole removal of your gallbladder. So normally we have 3 or 4 ports in the tummy, and we then basically the key anatomy for a lap chole, if you're in theater with the surgeon, he asks you, Callow's triangle is the key anatomy, and the triangle is made up of, on the roof is the inferior border of the liver, then the cystic duct and the common hepatic duct. So those are the borders of the triangle, and it's important because in the middle of the triangle you'll have the cystic artery. So you can see kind of on the picture here. So it's a key landmark that you look out for, and you dissect that triangle so that you can see what we call a critical view of safety, the cystic artery and the cystic duct. You place clips on both of them, you cut them, and then you remove the gallbladder from the base of the liver. Just in case they ask you this in the exam, some of the risks of a lap chole specific to the operation is damage to or bleeding from the cystic artery. You can damage the common bile duct, so that can be quite a significant injury and be life-changing actually for patients. It's quite rare, but it can happen. Bile leak after they've clipped the cystic duct, so normally manage that with the drain. And then about a third of patients will have some change in bowel habits following the procedure because their fat absorption has slightly changed. And if it's a challenging operation, you may have to convert to an open procedure. Okay. And we'll just talk about ascending cholangitis. So this is basically if you've had an obstruction and you've become septic from that obstruction, then you may get ascending cholangitis. So it's basically just means infection of the biliary tree. The other possible causes, ERCP can sometimes introduce bugs that can cause ascending cholangitis. The main organisms, E. coli, Klebsiella, and Enterococcus, sorry. And the clinical presentation is the classic Charcot's triad. So right upper quadrant pain, fever, and jaundice. So that's a very common exam question, actually. And just always try to remember that with ascending cholangitis. And then so the complications, so one of the sepsis and ascending cholangitis we discussed. Gallbladder perforation, if it's a really bad inflammation from cholecystitis, it can perforate occasionally. And sometimes you can get an empyema or a collection around the gallbladder. Quite often it can perforate and then seal itself off and become a big inflamed mass. So to be honest, for all of these things, ascending cholangitis, empyema, etc., the management is quite similar. So the first thing you want to do is your sepsis 6. Make sure you take cultures, lactate, make sure you check the lactate, send off your inflammation markers and your liver functions. Get antibiotics in as quickly as you can. Fluids, key. Make sure you're monitoring the urine output, catheter if you need to. Make sure you have the relevant imaging. So again, ultrasound, and then dilated ducts, go to MRCP, find out if there's an obstruction and where the obstruction is. These patients are often going to be, they can be pretty sick actually. So getting HDU involvement or ITU involvement early on is really important because they may go to ITU. They can get really sick in a really short period of time. So it's really key to stay on this. If they have an obstruction, ERCP is a good measure to relieve it, and that can relieve the sepsis basically. So if you can get that with the same day or the next day, that's good. If you can't, and or if it's a difficult thing to manage, for example, like they've had a perforation and a collection's developed, then you can speak to interventional radiology and they can place a drain, a cholecystostomy. So it basically just allows the bile to drain out through the skin, through the tube in the skin rather than through the biliary tree. And that can be basically a life-saving, procedure, particularly for your older, more frailer patients who may not be able to tolerate an ERCP, or who may not be able to tolerate surgery. Getting a drain in is very important. So that's pretty much it. I'll just conclude. So gallstones, common cause of right upper quadrant pain. Basically anyone who has right upper quadrant pain gets referred to a surgical team to rule out gallstone disease. Biliary colic, cholecystitis, inflammation of the gallbladder, choledocholithiasis, stone trapped in the common bile duct, or ascending cholangitis, which is infection, sepsis of the biliary tree. Ultrasound is so important as an investigation. MRCP, if it's showing like it's a dilated common bile duct, and if it is, then you can have stone clearance with the ERCP, and then they are almost all of them need their gallbladder taken out, lap coli. So finally, I've just put a revision slide if any of you find this useful just with a bit of summary of each one. That's it. I believe there's been some questions. Okay, so AST, ALT are more liver damage. Oops, sorry. For the first question about AST and ALT and cirrhosis, that I'm actually not sure of. I think chronic cirrhosis has been a while since I've done that. I mean, platelets are a good marker for inflammation and things, but I can't really answer that confidently.
I can comment on that a little bit. So AST and ALT can be chronically low in severe chronic cirrhosis. That's true. They can be below the level of normal. However, even in severe cirrhosis, if a patient comes in, say a patient's got severe chronic cirrhosis and they go on a binge and have a lot of alcohol and come with alcoholic hepatitis, there is no way the ALT and AST are going to be normal or low. It'll be high. So what's left of the hepatocytes can still generate a high AST or ALT if there's acute inflammation going on.
Yeah. Cholecystitis could be secondary to stones, and in that case, you'd see dilatation on the US. Yes, sorry, I probably should have clarified. So almost all cholecystitis is caused by gallstones. Occasionally, you can get something called acalculous cholecystitis, where you don't have gallstones, but that's quite rare. So almost all of it is secondary to stones. You're correct. The dilatation on the ultrasound. So the ultrasound, the gallbladder can be dilated. So which just means, so they'll say that the gallbladder is dilated and inflamed. That would be a sign of cholecystitis. But when I probably should have clarified, when I kept saying dilatation, I was talking about the common bile duct. So that's the thing that you're really focused on. Whether whether they've said the gallbladder is dilated or not is important, but the thing that's going to change your management really is dilatation of the common bile duct, because that then suggests there's a stone or a blockage distally. Why do we do urine dip in biliary colic? Yeah, it's nothing to do with biliary colic. It's just to make sure, as you said, that there's no renal stones or pyelonephritis, because it can be a similar area, and it's such a fast investigation that can save you a lot of embarrassment later on. So is cholecystitis exacerbated by consumption of fatty food as well? Once you've got cholecystitis, eating fatty foods, well, yeah, I think it won't make it worse, but it will prolong the episode, because you're causing that continual contraction, and you're preventing those stones from getting dislodged. So yeah, basically the best thing to prevent the biliary colic and cholecystitis is to reduce your fatty food intake. And to exclude DDs. I'm not sure what DDs is actually. Apologies. Potentially, do you mean duodenal ulcers? That might be, if to exclude duodenal ulcers is hard without an endoscopy. The one thing is that if you the presentation is slightly different with a duodenal ulcer. As I said, it might be more epigastric pain. There might be a slightly longer history of pain coming on just after you eat food, these kind of things. And perforated duodenal ulcer with an erect chest x-ray. And if your clinical suspicion is more of an ulcer, then you can arrange just an OGD to have a look. It just normally is a slightly different presentation, but it is easy to get caught out by that, and that can happen. And then how do you decide whether to do hot gallbladder? Ooh, there's a lot of questions, sorry. Or an outpatient chole. So normally if it's their first presentation of cholecystitis, and particularly if there is a complication, maybe even something like pancreatitis, where you know that there's and the stone has been cleared, but you know that there's going to be further complications from the gallstones, then doing a hot lap chole is quite useful. But only once their ducts are cleared. You need to make sure their ducts are cleared before you do a lap chole. Okay. So why is an ERCP? So you should almost always do an MRCP first to make sure that to visualize the biliary tree. Very occasionally, if you see it on CT or ultrasound and it's very clear where you know where the stone is, then you can go straight to an ERCP. And they also will do their investigation. They'll do their cholangiogram. But you mostly do an MRCP first so that they know 100% where the stone is. Okay. Need test to differentiate primary sclerosing cholangitis from. To differentiate sclerosing cholangitis, normally it's in the history. It's related to a lot of inflammatory disorders. And it's quite rare as well, primary sclerosing cholangitis. So often it's in the history. You'd be if they had, I don't know, I think it's like Crohn's disease and IBD, then you'd be thinking maybe it's possible. The other thing is the absence of any proper obstruction on ultrasound or MRCP. If you couldn't find anything, then that might indicate it's primary sclerosing cholangitis. Where am I? Can I check? Is there a fever in choledocholithiasis? Yeah, there can often be. But that is, if there's a fever, it suggests that it's developing into ascending cholangitis. So they're getting inflamed. They're becoming septic. Sorry. But quite often they won't have a fever. Basically, if you just have a bile duct that's blocked, then they won't have a fever. Okay. So where are we? Courvoisier's law is related to pancreatitis. So let me just, sorry. So it's basically where you have, there's another triad, which I've now forgotten. Is it painless jaundice? Painless jaundice is more related to malignancies, more likely to be a malignancy than biliary colic or gallstones. Oh, there we go. Yeah. Then Maritzi syndrome. Maritzi syndrome is basically when you have a stone that's trapped in the neck, or what's called Hartmann's pouch of the gallbladder, that's then pressing on I believe it's the common hepatic duct. So the important thing about Maritzi syndrome is it can be quite challenging to treat, particularly in a lap chole, because it makes your risk of injury of the common bile duct or the common hepatic duct a lot higher. Yeah, so ascending cholangitis only occur if there's a blockage of the common bile duct. What about cystic duct? Mostly it's basically a blockage of the common bile duct for two reasons. The first is if you remember Charcot's triad, it has to be the presence of jaundice, and if there's just a blockage of the cystic duct, the bile can still drain down the hepatic duct and the common bile duct. So normally you don't really have jaundice in just a blockage of the cystic duct, unless you have Maritzi syndrome, of course. Then also it's normally because you might become septic, but we wouldn't normally classify that as ascending cholangitis with cholecystitis. But yeah, sorry, I haven't really answered that very well. And guarding is basically caused by, is it the involuntary contraction of your rectus muscles to pain, basically when as you palpate and press the peritoneum, which has very good, you're able to very much localize pain on your peritoneum as you press that to the inflamed area. The purpose of guarding is to contract your rectus muscles and prevent bleeding. So that's basically what I think why it occurs. It's normally very difficult to distinguish between voluntary guarding, where the patient is just doesn't want to be in pain, and then true guarding, where it's an involuntary reaction that they're doing. So it's very hard, and actually almost everyone has voluntary guarding so that's the key thing, is just to make them relaxed, talk about their daily lives or their jobs, and what were they doing yesterday, these kind of things, and then just keep feeling their tummy until you feel it relax, and then you can see, hey, is this really guarding there, or is it just them, they don't want to be in pain, which is fair enough. I think we all do that. So I hope I've answered those questions okay. Yeah, testing my fluency.
I think that's been great. Thank you so much, guys. Listen, before you all run away and sign out, I do have I'll make one little clinical point, actually, which may be of interest. I suppose this is not right upper quadrant pain. It's more epigastric pain. As a cardiologist, one thing I frequently see is inferior ST elevation MIs presenting with epigastric pain. It seems to be a really, really common thing. I've certainly noticed it clinically a lot. So if you do have a patient with epigastric pain, never forget to do an ECG and a troponin. I think these are not, you'd be surprised how often, especially inferior MIs, just because of where your nerve endings are and where the pain gets referred, which will be kind of epigastric region, how often they can end up on a surgical take just because it looks like an acute abdomen or something. But it's really unclear because the abdominal, the liver function tests are fine, there's no actual guarding, but the patient seems really unwell with constant pain in epigastric region. But that's a real clinical kind of tip and trick. To be honest, A&E doctors and surgical registrars are very good at picking that up because they see it so frequently when they see a STEMI in front of them accidentally on a surgical ward round. So it is often picked up like that. I do have one more shout out to give. There's more people here, so I'll just repeat myself. We are looking for people to try and join the team. There's a few different things I'm looking for, actually. I'm going to put it into a Google form and put it onto a link on the page. So please do click on that. And if you are interested in joining us, do let me know and I'll be in touch. Our next talk is next week. We have a cardiologist named Niku Asminia. She's going to be teaching you all about murmurs for final year. So come prepared for that. It's going to be a fun little talk. Murmurs are always something that everyone hates. Well, I don't know anyone who loves them, so I don't think anyone loves them, actually. Everyone hates them. So it'll be something that'll be interesting for everyone. And of course, Corty will be back. I'm going to try and persuade him to come back and keep giving us some more surgical teaching. Thank you so much, Corty.
Thank you, everyone. Thanks for coming.
Thanks, everyone. Have a lovely day. Bye-bye.
Bye-bye.